Hi. So we're going to finish off this chapter discussing induced innovation and pharmaceutical regulation. Induced innovation is just what happens when people are spurred to conduct research on a particular kind of drug just because they can see the profit opportunity at the end of that. So it's when the market itself induces innovation in the researchers. So, for example, as the US population was aging, between 1970 and 2000, and they could foresee that that was going to continue. A lot of drug companies began to invest in creating drugs that would treat people over the age of 65, like glaucoma, for example. Even academic and public institutions engage in this kind of induced innovation, even though they're not necessarily drawing actual profits. So they're not, distributing profits to shareholders, for example, but they do get grant money and prestige and want to still treat like the things that are going to afflict the largest number of people. So, for example, a lot of academic researchers focus on obesity because it's growing a lot. So, who is harmed by induced innovation? Something that is like a rare disease, what they're called orphan diseases that afflict a very small number of people, are highly unlikely to have even an academic or public institution invest the considerable amount of resources necessary to develop a safe and effective drug. The same thing with tropical diseases that might only afflict people in developing countries who don't have a large pharmaceutical market or excess capital to spend on those kinds of treatments. They just end up getting less attention from researchers. Governments have tried to harness the power of induced innovation. So, for one, the Orphan Drug Act in the United States, it lets them have the patent for longer so that they get more time to recoup their upfront investment. And also things like advanced purchase of undiscovered vaccines for something like HIV, malaria, and TB. So it's like these might not be populations that they're not large populations and they might not be very rich populations, but by guaranteeing the sale, it makes it worth it for the company to invest in innovation. So that's induced innovation. Those are its problems. Finally, we're going to talk about regulation of the pharmaceutical industry. Today it's actually very tightly regulated, but it wasn't always the case. So before the 1930s, there was no real safety regulations or testing regulations for drugs in the US. What we had were magic elixirs. And then in 1960 in Europe, there was this drug called thalidomide. Thalidomide was supposed to be prescribed to pregnant women for morning sickness, but it ended up causing birth defects for 10,000 newborns and was then pulled from the shelves and promoted stricter drug regulation throughout the world as a result of this like massive calamity. So then the Coe-Pfeffer Harris Amendment in the United States, just a couple of years later, required that companies prove that their drugs are safe and efficacious before they bring them to market. And those stricter regulations led to a lower number of new chemical entities coming to market over the following decade. It's probably okay, right? But maybe some of those new chemical entities would have been good. But we have to just be really strict. So with pharmaceutical innovation, you're balancing type 1 and type 2 errors. You might remember this distinction from your biostatistics class, but a type 1 error is when a bad drug is approved. It's a lot worse. A type 2 error is when a good drug is rejected or delayed. Phase 3 trials are not going to have complete information about a drug. It's like it's lab conditions. They had to pick particular people to be part of their sample. In the real world, people might have comorbidities. People might not be exactly as adherent. So you don't have perfect information even after the phase 3 trial. And you have to use that information to try to decide what to accept and what to reject if you are the FDA regulator. But the thing is that you're always going to have some error. right? So at T star here, you're rejecting the vast majority of the bad drugs, but you're approving not all of the good drugs. No matter where you put that T star, even if you move it to the very edge of the bad drug hump, um, and you reject all of the bad drugs, you're rejecting a majority of the good drugs. So no matter what, you're going to have some error. Regulators have to try to balance the social welfare that would come from having drugs that are useful against the potential harm of approving bad drugs. You have more of an incentive to avoid type 1 errors because of media attention. The type 2 errors are not as sensational for the media. And also, I think you have more incentive to avoid type 1 errors because you don't want to actually make people worse off than they already are. So there are other forms of regulations between consumers and their prescriptions. Physicians have prescription power in most countries, including the United States. So there's less abuse of drugs because you have to have a doctor in between yourself and that drug to some degree. But there is more cost to the consumer, time, inconvenience, and expense of seeing a doctor to get your prescription. They also put bans on direct-to-consumer advertising in a lot of countries, not in the United States. Here you'll see the commercial, and they'll have like the little dot kind of bouncing across the TV screen, and it has a face on it, and it's sad. And it's like, are you sad too? You can get this kind of prescription for depression. So there are benefits, like with anything, there are costs and benefits. The benefit is that it can reduce the strain on the doctor patient. Oh, having a ban, sorry, I was like confused. Having the ban reduces strain on the doctor patient relationship. So you see that commercial, you go in and you tell your physician, this is the drug I need. But the physician might have other information that you don't have about your condition and about the range of possible drugs that you could take. And you wanted one thing, the doctor says you should have something else. It can put some strain on that relationship. It can create a tension. Having that ban can also prevent moral hazard. People might be more like inclined to consume a drug because of the insurance, because they saw moral hazard can also act in this case where if you see the commercial, you just want that drug. And you might want to be overtreated relative to what's actually necessary. But the costs of banning direct-to-consumer advertising is that you might not get the information about the drug that will benefit you. So again, regulators have to weigh these things against each other. So in conclusion, there are a range of trade-offs that we've gone over with respect to regulating the pharmaceutical industry. One is patents. One is because with patents, you want to incentivize innovation by protecting that legal monopoly, but you also need affordable prescriptions, so you can't make it for too long. With government price controls, you are risking innovation because you're reducing the price, you're negotiating lower prices. And on the other hand, it's good because you want affordability. So you have to balance like the prevention of innovation through not being able to recoup their costs versus maintaining affordable drugs for the population. FDA regulations, you want more new drugs and you want fewer dangerous drugs. So how many should you, how lax should your standards for approval be? You have to balance that between type 1 and type 2 errors, where you're approving bad drugs with type 1 errors, but you're declining good drugs with type 2 errors. And finally, physician prescriptions, physicians being the ones in charge of prescriptions, it increases safety of drug use, but it can also make the drug more expensive because consumers now have to add the cost of the physician to the cost of the prescription. And that's it for this week.